Hi everyone, thank you so much for having me. Let me start by first introducing myself. Well, my name is Allan Kimaina. I completed my master's degree in biostatistics at Brown University with a concentration in health data science track. I am currently based in Eldoret, Kenya, where I'm actively supporting AMPATH in various research, spanning HIV care, mental health, universal health coverage, and general population health. Starting with the background, significance, and rationale for this study, it is well known that HIV virologic failure occurs when viral RNA is elevated to a certain threshold, usually 1,000 copies per ml as per the WHO guidelines. And if not detected and addressed, it can easily escalate to treatment failure, immunologic failure, or clinical failure. Fortunately, due to the influx of HIV electronic health record data, it is becoming more feasible to predict these clinical events. Therefore, this study aims to disseminate some techniques that can be utilized in HIV care programs to proactively anticipate and mitigate potential risk of virologic failure. The big question here really is, how is this going to help a clinician? Well, the trained and validated models can potentially be utilized in HIV clinical settings with rich electronic health record data to enhance clinical decision support systems for monitoring HIV viral load. We are currently in the process of conducting a retrospective observational study by creating temporal risk predictive models using IDEA data. Starting from the far left, the input X for the models are over 50 clinical and non-clinical profile, which constitutes demographics, lab findings, medication history, and other key predictors. On the far right, the output Y is a binary indicator of failure, which can be expressed as a probabilistic outcome. So, we are trying to learn the G of X that can be generalized across care programs and different countries within East Africa. Now coming to the results section. So far, we've been able to make a few critical milestones. For example, we've been able to figure out the viral load limit of detectability across care programs, different countries, and over time. In general, most care programs have a lower detectability limit of approximately 50 or less, with notable exception of Marara, whose limit is approximately 400, as shown on the far mid-right panel. Also, as of today, we've been able to complete univariate analysis, bivariate analysis, and part of missing data analysis. For example, on the table shown in the left panel, we can see some of the key clinical and social demographics predicted that were highly correlated with the response variable. In fact, most predictors were statistically significant at 0.005 level. Apart from that, we plan to characterize and compare AUC, sensitivity, and specificity for popular machine learning models. Already, the preliminary results for predicting fast virologic failure using baseline covariates shows very promising results as shown in the right panel. We are also looking at model interpretability, and some of the methodology we are utilizing include classical variable importance rankings, as shown on the left panel, as well as partial dependency plots, as shown on the right panel. As I wind up, I wish to express my very profound appreciation to all my mentors for their incredible support. Starting from the far left, we have Professor Kara, Bev, Professor Joe Hogan, Dr. Agri, and Professor Constantine. I can say without them, none of this would have been possible. I'm forever grateful. Also, I wish to convey my sincere appreciation to the amazing team at Fogarty and IDEA for facilitating the FIMP mentorship programs. Lastly, I wish to thank you for taking time to participate in this presentation. Thank you so much.
Thank you very much, Allan, for that presentation. Are you online?
Yes, I'm online. Thank you, Priscilla.
Great. We have a question from Matthias who says, great talk, Allan. How did you deal with missing data?
So right now we are taking advantage of the missingness. Sometimes a model can learn the missingness pattern by just including a binary indicator for missingness as well as adding it into the model. The machine learning algorithms such as GBM, XGBoost, and other popular machine learning are able to figure out the missingness and actually generate the signal. So that's what we're handling right now. For the response variable, such as virologic failure, we are not including in the model as of now. We have not been able to figure out how to handle such cases. And maybe for future analysis, we might need to handle for cases where we are missing viral load for particular cohorts of patients, such as those who are lost to follow-up and so on.
Thank you, Allan, for that response. I don't know, Matthias, are you answered?
Yeah, I'm just wondering, you basically feed it into the machine learning algorithm, but it's not very transparent how the algorithm deals with the missingness. So thanks for the answer. I think I understand what you're doing, but I don't understand whether this deals with the missing data problem appropriately, let's put it that way. But I'm not a specialist myself, so I was just wondering. Thank you.
Thank you, Matthias. And we are still exploring this issue of missingness. We are yet to settle on a particular approach, but for starters, we've decided to start with just feeding the missingness binary indicator to the model. But this is something we can follow up for sure. Thank you, Matthias.
Thank you for that, Allan. I just also had a quick question with regards to how you intend the results from this analysis to be used. Is it something that will just be used, like, for example, by fellow statisticians when they're doing their own analysis? Or are you also going to develop a model that a clinician can actually use when they're in front of a patient and trying to, decide who to send for that viral load maybe earlier than what the guidelines stipulate, etc.?
Thank you so much for that question. And just to answer your question, we are actually hoping that we'll be able to generate a model that can be fed into an electronic health record data system, electronic EHR system, and it can be consumed by most popular point of care systems. And clinicians can actually use it to make clinical decision support, especially in the clinical decision support systems. So that is one of the objectives. And we are hoping to start with AMPAT once we get the right approval.
Okay, great. Thanks for that response, Allan. And thanks for the lovely presentation.